Hi there, everyone. Thank you for tuning into this and welcome to our very first live discussion of the Academy of Pediatric Physical Therapy Student and New Professional Subcommittee. My name is Nick Sell. I will be your moderator for this evening and hopefully for future evenings. And I just want to welcome you and say thank you again for joining me. So, as you may already know or may not know, the purpose of these videos, first and foremost, is to introduce and inform about a topic that's relevant to pediatric physical therapy. So that can be a wide range of things. Tonight we're focusing on just one, but in the future we'll cover hopefully a lot of different topics related to this area of physical therapy practice. This is going to include some review of current literature and evidence surrounding the topic that has been chosen, as well as provide an additional outlet for students, new professionals, and others who are interested to ask questions and have them answered live here on our discussion. So hopefully we get questions from people who are watching. If not, I have enough information to kind of talk about this for a good probably 30 minutes is the plan, so about a half an hour. If we get more questions that lead us to go longer, that's great. That's encouraged. Otherwise, we'll probably go about half an hour. So again, the format's just to provide information about the topic, provide resources, and then again, I'll try to answer questions to the best of my ability. Forewarning, I may not be able to answer every single question adequately. I think that's to be expected, but I also think and I hope that over time we can get people kind of responding to questions that maybe members or viewers of this have, people that are better able to answer the question than I myself am. And if not, I'm always willing to look something up and try to find out more information about it as well. So I appreciate your patience on that. A little bit of information about myself, just first and foremost. I'm a second year, soon to be third year DPT student at the University of Minnesota Twin Cities. Interested in pediatric physical therapy, obviously. I've had a lot of experience in a lot of different settings within pediatrics, and I've loved them all. So I'm excited for this career, and I'm passionate about this area of physical therapy. So again, I thank you, everyone, for this opportunity, and hopefully we get some people interested and we can learn some more about pediatric PT. Also, as a disclaimer, again, this is our first time doing this, so if there's technical difficulties or if I'm not answering your tweets and you're sending them in and I'm just not seeing them, I apologize up front. Hopefully none of that happens, but if it does, hopefully, bear with us and we will move forward. So, to introduce our topic for tonight, we are focusing on children with complex medical needs and how pediatric physical therapists work into the care of these children and families. And so, first of all, let's maybe just define what complex medical needs are for those who maybe not have exposure to this population of patients. So there's actually a lot of different definitions of what a complex medical need is. One more recent definition that was purported by Logan et al. In the article titled Modified Ride-On Car Use by Children with Complex Medical Needs in a previous 2015 issue of Pediatric Physical Therapy. They define complex medical needs in children as any child who is chronically critically ill, who may have long-term mechanical ventilator dependence or is otherwise chronically medically supported. A majority of these individuals may have more than one primary diagnosis, with the most common clinical conditions including genetic or congenital, neuromuscular, cancer, respiratory, gastrointestinal, and cardiovascular conditions. And why this topic is important is because a recent estimate puts the incidence of complex medical needs in children anywhere from 6 to 14 out of every 100,000 children living today. So, it's a small percentage, but it's definitely a significant percentage, and it's something that certainly, if you're going to work in pediatrics, you're very likely to encounter children with a diagnosis that might be considered complex, and that can be anywhere from an inpatient acute setting to a home setting where children may be considered medically fragile, or they may be on something like hospice or end-of-life palliative care. So really, you can meet these kids and families anywhere you are. And so that's why we've kind of decided to focus tonight's topic on this group of individuals. Another way to maybe think about this population of kids is almost in a sense that they have more challenging presentations than a typical child would. So if we were to frame it in something like a gross motor functional classification scale manner, where for those of you who don't know, GM-FCS levels is what they're called, can range anywhere from a level 1 or to a level 5, level 5 being the most involved. And so if we think about it in those terms, and it's usually used to classify kids who have a diagnosis of cerebral palsy, if we think about it in those terms, a child who would be classified as a GM-FCS level 4 would be considered a child who has self-mobility with limitations, and these children are usually transported either using a powered mobility device in the outdoor setting or in their community. And a level 5 GM-FCS would be considered a child whose self-mobility is considered severely limited, even with the use of assistive technology. So for the new professionals out there, you can probably picture a kiddo or two on your caseload who may fit these classifications or who may fit into this category of complex needs. For students, you may not have exposure to this, or you may, if you've had some experience in pediatrics, if you can think of maybe just some of the more involved kids that you've seen shadowing or volunteering, probably would be considered in this classification. And again, other things we can use to kind of consider this population: mechanical ventilation, the setting that they're in. So inpatient may be considered a more intensive setting. You may be more likely to encounter these kids in that area. The number and the nature of the child's diagnosis. So the more diagnoses a child has, likely the more complex their medical condition is going to be considered. As well as, if it's a life-limiting condition, maybe something like cancer or a neuromuscular disease such as muscular dystrophy, where the life expectancy of the child is considered to be less than a typically developing child, that could be also considered something that's complex. So those are all things to keep in mind when we're talking about this population. So as far as the literature that surrounds I'll take a break here and just announce, if you do have a question to send in, feel free to tweet at Nick Sell SPT on Twitter. So at capital NIK, capital SELL, capital S, capital P, capital T. And you can send your questions to that Twitter handle. Again, we're still figuring it out, so hopefully it goes through. But if you do have a question, please send it to that location on Twitter. Okay, moving on to some of the current literature surrounding this topic. So Heathcock et al., 2015, in the journal Pediatric Physical Therapy, recently did a case series titled Daily Intervention for Young Children with Cerebral Palsy in GM-FCS Level 5. So again, that's the most involved kids. Usually self-mobility is severely limited. They may be able to ambulate or locomote with assistive technology, may not be. But that's who we're talking about. So So the purpose of this case series was to describe a daily physical therapy intervention and outcomes for 2 young children with spastic quadriplegia, so that's cerebral palsy, GM-FCS level 5, and to evaluate the feasibility of using a daily program in an urban children's hospital outpatient setting. So that's kind of the background. Summary of the key points of this article. Subjects were 2 young children, again, level 5 GM-FCS. They received 2 hours of physical therapy intervention based on motor learning principles for 5 days a week for 4 consecutive weeks. So that would be considered an intensive therapy program. Outcome measures included the gross motor functional measure and the Bailey scales of infant development, both pre and post intervention. And the results of this study was that this daily intensive therapy was well tolerated by both kids, and they found improvements in motor function, language, and cognitive skills. And so their conclusion, the authors, was that a daily PT program appears feasible and may improve overall development in young children with cerebral palsy in GM-FCS level 5. And so I think that this is, right off the bat, very important to consider both as students, as future clinicians, and as current practitioners for the new professionals who are tuning in. And that I think it gives us, while it's a case series, it gives us some level of evidence that intensive therapy can be feasible and result in positive outcomes for children who would be considered probably the most involved or the most complex that a physical therapist might see. And I think that's important because I think whether we mean to or not, the kind of the thought process around not just kids but individuals in general with some of the most complex needs is that intensive therapy, first of all, may not be well tolerated by these individuals. And so what I think this gives us is a concrete example that kids of the highest classification in terms of gross motor functional classification level do tolerate intensive therapy. And then secondly, I think the thought that the potential outcomes for this population may not warrant intensive therapy. I think this also gives us a concrete example that we can have positive outcomes with this population despite their seemingly more complex and more involved presentation. So I think that's important for us to consider. Okay, so our next article was one that I referenced earlier by Logan et al. In that same journal, Pediatric Physical Therapy, also from this year, titled Modified Ride-On Car Use by Children with Complex Medical Needs. I just got a tweet from a member of our subcommittee, Sarah. Thanks for tweeting in. And she told me that Heath Cock, the lead author on that article that I just mentioned, just received a large grant to continue his research. So that is very encouraging, actually, that people out there are recognizing that this is a population of patients that there's a need to be met here, and it's a need that can be met by physical therapists in an intense type of intervention. So thank you, Sarah. That's cool to know. So back to the Logan article. Their purpose was to determine the feasibility of short-term modified ride-on car use for exploration and enjoyment by children with complex medical needs, so specifically this population. And for those of you who aren't familiar with the ride-on car almost craze right now, a lot of specifically there's a lab you can look up at the University of Delaware that's doing most of the research on this. But the idea is that therapists working in conjunction with other professionals, typically some engineers and other people who may be involved, are taking sort of those cars that you might see, at a Target or a Walmart, and modifying and adapting them for children with complex needs who may not otherwise be ambulatory, and allowing them to use these vehicles to engage in social interaction, engage in their environment by instead of ambulating independently, using these cars to navigate their environment, either with a switch maybe that they can use with their, a finger or with their head, depending on the amount of control that they have, really with the goal of just increasing independence and interaction in their environment and participation in their daily life. So that's kind of the background. This study in particular looked at 3 subjects. They were anywhere from 6 months to 5 years old, all classified as having complex medical needs. And basically they just wanted to see if this was enjoyed by these kids and if it was feasible. And so the results of their study were that all children, all 3 of them, successfully learned how to independently drive the modified ride-on car. 2 out of the 3 demonstrated high levels of enjoyment during use of the car. So their conclusions were that modified ride-on car use is a feasible and enjoyable powered mobility device for children with complex medical needs. And so I think this is, again, an awesome article that gives us kind of at least some guidance in terms of what we can even do with kids who may have complex medical needs that before we may have said that, there's a limited repertoire of things that we have in store for these kids. This gives us an example of something that's relatively inexpensive that we can use to increase their enjoyment and their interaction with their environment. And so I think for me the biggest takeaway of this article was the focus on participation and enjoyment in a real life setting. I think these kids clearly had a good time using this car. At least 2 out of the 3 did, which is promising for a small study like this. And so I think it just really highlights not only that we have something for these kids, but also the importance of thinking about not just maybe the body structure and function side of therapy, but also the importance of participation on kids' lives, and especially those kids with complex needs that may not otherwise have a typical amount of social interaction or ability to navigate their environment on their own. Now we have something for them that can hopefully help with that. So that was really good to see within this article. So I think we will continue on here. There's a few more articles I have to go over. Let's see. Let's focus on our next one by Martinson and Himmelman in 2011, again in the same journal, Pediatric Physical Therapy, titled Effective Weight Bearing in Abduction and Extension on Hip Stability in Children with Cerebral Palsy. And so the purpose of this study was to study the effect of 1 year, so it's a fairly long period of time, of daily straddled weight bearing on hip migration percentage, which was basically the amount that the hip skeletal structure moved throughout the year, and muscle length, so adductor muscle length, in children with cerebral palsy who were non-ambulatory. So their subjects were kids with cerebral palsy, and they had a GM-FCS level between 3 and 5 years old was part of the inclusion criteria. And then children at GM-FCS level 3 who were already ambulatory were excluded from the study. So this was purely kids who would normally be non-ambulatory locomotors. And so the results of this study were that, I should mention too, they also used a control group. So they compared this group of participants to a control group. And the intervention group was in the standard in maximum tolerated hip abduction and hip and knee extension for a half hour to 1.5 hours per day for 1 year. So this is pretty intense as far as standing and therapy goes. So the results were, they found that participants using the straddled weight bearing after surgery had the largest decrease in hip migration percentage. So that would be a positive result. Children using the straddled weight bearing at least 1 hour per day for prevention, so those who did not get therapy, also improved. And then hip and knee contractures were found only in control subjects. So none of the participants who used the standing program. And the controls were matched for age, motor ability, and surgery, and they also had a diagnosis of cerebral palsy. So the conclusion of this study from these authors was that straddled weight bearing for 1 hour per day may reduce the migration percentage after adductor iliopsoas tenotomies or prevent a further increase in hip migration percentage in those children with cerebral palsy who did not need surgery. They did say that larger studies are needed to confirm the results, but I think this is just another example of the tolerance of an intensive therapy program for kids who would be considered complex or have a higher level of need for therapy services. So 1 hour, half hour to 1.5 hours per day of a standing program would, for an entire year, would be considered pretty intensive intervention, and these kids tolerated it well. So that was encouraging to see. I think we'll move on to one more study, as long as we don't have any questions coming in for the time being. I don't see any on my page, so I think we will continue to press onward. So the final article that I'll discuss tonight is by Hong et al., also from 2015. This article was from the European Journal of Pediatric Neurology, and the title of the study was Gross Motor Outcome of, just reading a message, seeing if there's a question, but we're good. So the title is Gross Motor Outcome of Intensive Therapy in Children with Cerebral Palsy and Developmental Delay. So the objective of this article was the authors talked about the fact that many physicians and parents of children with developmental delay do expect some effect of intensive rehabilitation treatment, though the evidence for intensive rehabilitation and intervention is not well defined, which we've talked about. Indications of intensive therapy and factors that can have an influence on therapeutic effect are not well known. So again, further reason to study this further. So the aim of this study for these authors was to find out the short-term effect of intensive therapy, which for this study was 3 hours per day for 5 days a week for 8 weeks, and consisted of physical and occupational therapy, on gross motor function in children with developmental delay. So the methods here, the authors retrospectively studied 84 patients, and total gross motor function score percentages were analyzed. The mean age was 35 months old. 46 children had cerebral palsy due to prematurity. 22 patients had cerebral palsy at full term. And 8 patients had a genetic abnormality. And then 8 patients had a developmental delay of unknown origin. The number of patients, according to the GM-FCS levels, were 11, 17, 12, 22, and 22 on each GM-FCS level 1 through 5, respectively. So just to go over that again, that's 22 each in GM-FCS level 4 and level 5. So a pretty significant bunch of these were from the higher classifications of GM-FCS levels. So the conclusions or the results of these authors were that the gross motor function measure, GMFM score percentage change, was significantly improved after 8 weeks of therapy, intensive therapy. They did find that improvement was greater in mild to moderate groups of children, so those GM-FCS levels 1 through 3, as compared to GM-FCS levels 4 through 5. And they also found that patients of 36 months or older improved more significantly than 36 months or younger improved more than patients older than 36 months. So the younger tended to improve more than the older group. Causative disease, so the diagnosis, and botulinum toxin injection did not have an effect on the gross motor outcome However, children without seizure disorder showed significantly better effects than those with seizure disorder. And so the conclusion of these authors was that intensive therapy did end up being more effective in the children who would be considered less severe cerebral palsy, so those in levels 1 through 3, compared to those in levels 4 through 5. Also, the younger age, so 36 months or younger, had a positive influence on the gross motor outcome, and the children without seizure disorder had a better effect than those with seizure disorder. So the main points from this article I think to take away are, number one, that the gross motor function of these kids did improve significantly after 8 weeks of intensive therapy. It may have been more in children who were considered had a less severe diagnosis of cerebral palsy, but I think we need to also consider that all groups did significantly improve after 8 weeks, and I would call this a victory for those who work with children with complex medical needs who may believe that intensive therapy is indicated for their individual patient. I think this was shown to be feasible and tolerated by these kids, and I think from the evidence that we have right now, that's a huge deal, and it's something that we need to definitely consider with our patients moving forward. So to leave the literature review side of things and go into just a little bit more about this topic. For those of you who already work with kids who may be considered to have complex medical needs in whatever setting, some resources that you can check out if you haven't already. The Academy of Pediatric Physical Therapy, formerly Section on Pediatrics. Their website has a lot of great resources, and specifically if you tune in or go to their webpage and click on the fact sheet section of things, there are two fact sheets in particular that would be especially helpful for considering the intensity of services for kids with complex medical needs that you may service in your practice. So the first fact sheet is titled Intensity of Service in an Outpatient Setting for Children with Chronic Conditions. And then the second fact sheet would be for those working in an acute setting. It's titled Frequency and Duration of Physical Therapy Services in the Acute Care Pediatric Setting. And those both have very detailed and in-depth descriptions and hopefully helpful guidelines to determine sort of what may be feasible, what may be the best level of intensity of physical therapy services to offer for your kiddo with a complex medical need. In addition to considering the literature that we've reviewed here and others that have been published. I certainly haven't touched on everything, but hopefully these have been trying to focus on some of the more recent articles that have come out around this topic. So, to wrap up, unless we have any questions coming in, I'll wait on that. But if not, just to summarize some of the key points of this topic tonight. Number one, I think that we should consider the fact that we need to not underestimate the potential of kids with complex medical conditions. I think, knowingly or not, a lot of us, including those in the medical profession, may not consider the efficacy and indication of intensive services for children with complex needs. That may be from our own background and schooling that we've learned that intensive therapy is not necessarily the most researched topic on these kids, and so we may be hesitant to attempt it. It may also be from a standpoint we have to consider, other factors such as insurance coverage of whether or not, intensive therapy services are going to be covered for these kids or not. I think with more and more literature coming out, hopefully it becomes easier and easier for therapists to justify intensive services for these kids based on the outcomes and the positive outcomes that have been shown in research and hopefully continue to be shown. But I think, number one, we need to not underestimate the potential of these kids because there certainly is potential for positive gains in a lot of different areas for these kids with intensive therapy if it's well tolerated. So my second key point is to just do your research in determining whether intensive therapy is indicated or appropriate for the specific child you're seeing. Certainly this may not be the case in all settings. An example of some current research that's being done and kind of a hot topic is if we consider early mobilization in the pediatric intensive care unit. Some practitioners will say this is something that's indicated and should be done for a lot of different reasons, deconditioning being number one. Other practitioners may conclude, based on a number of factors, that early mobilization is not indicated due to safety concerns or other considerations in the pediatric intensive care unit. It's not a hard and fast answer to something like that. So in determining whether intensive therapy is something to be considered, I think doing your research and considering the individual child is a must. My third point is to consider the family's and the child's goals. So I think a lot of times, again, not from a standpoint of not believing in the child or the family's abilities, I think we almost discount what the family or the child themselves may want to do based on their presentation. So I think it's important to absolutely consider the family's and the child's goals if they're able to articulate those in determining, intensity or even the appropriateness of therapy itself. As with any child, but I think especially with this population, it's important to really listen to the family and what they want for their child and do the best that we can to help them with that, and not discount the potential for these kids to participate fully in their daily lives. I think we have tools that are growing by the day in terms of what we can offer these kids and these families for ways to increase their participation, whether that be resources to something like an inclusive playground that their child can play with their siblings or their friends that they wouldn't normally be able to what we talked about earlier, like a modified ride-on car where it's a relatively inexpensive and cheap option that the family can explore that may allow their child to participate more fully in school life. So I think definitely considering the child and the family and what their goals are is a must for this population. Fourth, like I said, focus on participation and what the child is able to do. Don't look at the diagnosis of the child and assume that you know what their abilities may be or what their potential to participate in their lives may be. There's a number of factors that go into those things: the motivation of the child, the motivation of the family, the resources of the child and family, your expertise and what you have to bring to the table. I think we need to absolutely focus on what the child can do because there is a lot that these kids can do. I think we just need to give them a chance, and we need to be certainly a positive force and an advocate for these kids because many people may not be. And these kids absolutely deserve everything that a typically developing child or even a child with what would be considered a less complex condition should have access to. So I think just keeping that in mind and keeping an open mind for these kids and these families is absolutely important. My last point is just to understand that this is obviously a developing area of physical therapy, and there are still many questions that need to be answered in terms of how we see and treat children and families of children with complex medical needs. And so this certainly isn't the end of the discussion, obviously, but I hope it's a good place to start, and I hope it helps at least some of us reconsider the potential of these kids and what we have to offer them, because we have a lot to offer them and they have a lot to offer to the world. And I think the more we see that as a profession, the better outcomes we're going to have, and the more happy kids we're gonna send back to their lives. And I think that's the most important thing. So in closing, I will just say thank you again for those who tuned in. Hopefully this was informative. Please, if you have questions, feel free to tweet at NickSellSPT whether that's tonight or in the future, whether it's about this topic or something else that I can be of help with or our subcommittee can be of help with. We would love to hear from you, so we appreciate that. You can also send us an email. Feel free to send me an email. My address is sopsnpsoc@gmail.com. I check that just as frequently, so feel free to send me questions or concerns or suggestions about this discussion as you feel necessary or fit. Again, we'd love to hear from you, and we appreciate your interest in this subcommittee and this discussion. Hopefully, we can carry it forward. So, our next topic is yet to be determined. Hopefully, will be in about a month from tonight. And feel free again to submit ideas. We don't have to talk about any one thing in particular. If someone has an idea that they're particularly passionate about or want to know more about or want to just have a discussion with peers and potential mentors about, that would be awesome. We would love to hear what you want to hear about. So feel free to let us know that either on my Twitter page, email, or you can send it to our Facebook page as well. We would love to hear from you. So with that, if there are no questions, I think I will sign off. And again, thank you, and we hope to hear from you next time.